Depending on where you're watching this, you may or may not already know who I am. My name is Kate Finamore, and I'm the director and an instructor at Engage Fitness Collective, where we've been talking about how May is Arthritis Awareness Month. And so I wanted to talk to Jen here, who we've known each other like 20 years. And Jen is my neighbor, but she is also our family physical therapist, if you will, because we kind of keep a host of practitioners in our little Rolodex. So Jen has seen multiple people in my family for physical therapy and really honestly for sort of skills coaching around mental fitness and chronic pain. And so I just thought she would have a lot of great things to share. So I'm going to let her tell you a little bit about herself. And also, she just came from somewhere really interesting. So Jen, tell us about you.
I did. I'm going to get you all excited about where I came from first, is that I got back yesterday from the International Pain Science in Motion Congress, which is all about the latest on research. So I'm very excited because there are a couple things specific to arthritis. So I'm happy to share those with you. I am a physical therapist. I have been a physical therapist for way over 30 years. And then I'm very passionate about bringing pain science and mental fitness together. And along with that, I also do lifestyle medicine coaching. So within all of those things, this gives us a great toolbox to help people get to where they want to be in their lives with less pain.
Yeah. So as a fitness instructor, I hear all the time, somebody will be like, "Oh, I'm not going to lunge today. My knee is really bothering me." And, I'm not a doctor, so I always tell people, like, be kind to your body, like pay attention to what it's trying to tell you. But a question that I hear often, and I'm guessing that you hear often, is like, my knee, my back, whatever it is, my hip hurts so much, but my doctor says I only have like mild arthritis. Like, can you talk to us a little bit about why that might be?
Yes, this is probably one of the biggest myths around pain, is that the myth is if we feel pain, something is wrong. So we're going to zoom out a little bit because pain is complex and it involves literally every system of your body. So if you sprain your ankle, yes, you will feel pain there. However, the pain is not technically sourced from your ankle. That's where you feel it. And it's also important to say here that all pain is real. We have never, ever scanned fake pain. However, pain, depending on how it shows up, how it progresses, what your personal story and history are, is going to change the way we choose to treat it. And we actually, pain science geeks, we like to say that we are treating pain rather than managing pain. Nobody wants to treat the flu, nobody wants to manage the flu. They actually want to treat it and move on. So that's my quick summary there, is pain is just so much more complex than the tissues that we have. And we have many, many people who have horrendous looking scans and they have no pain. And then
This
we
is
have the opposite.
Yeah.
Yeah.
This is the part that I find fascinating. I just find it fascinating. So the term that I've come across is neuroplastic pain. Like the idea that, just like what you said, no one is saying that your pain isn't real. All pain is real. No one's pretending to have, like, I don't, or they're making it up. No, your pain is real. The question is, how did you get to that state where you feel that pain, if in fact your arthritis is mild, or if in fact the vice versa, if you have somebody who has a scan that makes it look like they should have terrible pain, but they don't. So can you talk to us a little bit about neuroplastic pain, or whatever terminology somebody might use for something like that?
I am, but I'd like to give you a little bit of information, and some of this is hot off the presses, and some of it is my previous knowledge about, in particular, arthritis and pain. So we've done lots of different studies on people, and what percentage of people, Kate, I think you know the answer already, so just pretend. What percentage of people who have knee arthritis have pain?
Oh, what percent? Well, I mean, I don't, that's hard to know because I think a lot of people have knee arthritis and they don't even know they have it because they have zero pain.
Right. So that's a good introduction. You always come at things from an angle that makes me think harder. So of the people who are complaining of pain, about 50% of people with arthritis have pain. And so that means that 50% of people who have arthritis do not have pain. Here's another fun little fact, is that every single one of us starts to develop arthritis in our 20s. It is normal. There's a lot of things that I will not credit aging for. However, arthritic changes, this is a normal part of aging. We like to call it wrinkles on the inside. People don't like wrinkles, but it's not a health, detriment. We don't need to have surgery. Okay, some do, but that's a different topic. However, arthritis is a normal part of aging. So if you're having pain, we have to get a little bit more curious beyond just that diagnosis of arthritis. So we actually talk, the fancy term is pain phenotypes, and I have a little fun demonstration for you today. So I have to prep my very fancy stage here. So we're going to have a little game, Kate. So we have these 3 different pain buckets. The fancy word is phenotypes. And so what I'm going to do, and people that like to take notes, this is a good time, is I'm going to give you the key descriptors of nociceptive pain. This is the pain that nobody really even cares about. You have sprained your ankle, in a week or 2, you're good to go. You burn your hand on the hot stove, a few days later, you're good to go. And then we're going to talk about peripheral neuropathic pain, which has different characteristics. And then, Kate, your original question was nociplastic pain, which is where we are having increased sensitivity. So I'm going to phrase this one as tissue issues. So, Kate, do you want to know one characteristic of nociceptive pain?
Yes, please. I love props.
All right. People who have nociceptive pain, tends to be intermittent pain. It is sharp, it is dull, and it is throbbing. Now, I'm also going to let you know that we aren't ever in the same bucket. They can all intertwine. But as a physical therapist, my job is to figure out which is your dominant bucket, because our treatment regime is very different depending on what your dominant bucket is, and it can change. Okay, what else can we learn about nociceptive pain? We can learn that there are particular patterns when people have nociceptive pain that increase or decrease your symptoms. So you sprain your ankle, and walking on your ankle hurts. When you get off of your ankle, it no longer hurts. Maybe going upstairs hurts predictably, but not downstairs. Predictable patterns is another indication of primarily tissue issues.
Tissue issues.
Tissue issues. Okay, the next one is that we see a connection between the pain and the injury. So let's do something other than the sprain. You bonk your head on a cabinet, that's gonna hurt. We expect that to hurt. We expect it to resolve within a few days. Maybe if it's a significant concussion, it will take longer. However, if somebody gets, let's see, they just bump their hand into a door jamb as they're walking through, and their pain is going on for months and years, which happens, then we have to get more curious. So when the pain intensity and description match the symptoms, we're looking more at nociceptive pain. And our last little category here is, generally, we are not going to see burning pain, shooting pain, or electrical sensations.
Ah,
So
that would
there
fall
you go.
into your
That's
next
number 1.
bucket.
Number 2, and it's kind of in a progression here, peripheral neuropathic pain. Peripheral means of the body. So we're less about the brain and how that's functioning, and more about what's going on in the nerves in our body. We can't really take them all apart, but we can try a little bit. So our first characteristic of generally nerve pain is that this requires the help of a clinician, whether it's a doctor or physical therapist. We are going to see positive findings. There are several different things we can do to test happiness in nerves, is what I call it. We're looking at the mobility, the freedom of the nerve. And then also there's different parts in the body where the nerves are really accessible. I don't ever expect them to be sensitive. However, somebody who's had a peripheral neuropathic injury, they may be sensitive to palpation where nerves are accessible. Think funny bone. Most of us have hit our funny bone.
Okay. Would you put sciatica in this category?
It would depend on how that sciatica was sourced. If that sciatica came out of the blue, I would not call that peripheral neuropathic pain. If that sciatica came from maybe an impact injury, you fell and landed on your butt, then maybe so. And we're going to get to that. That's in one of our final 2 things. All right, what else do we know about peripheral neuropathic pain? We know that the pain follows the pattern of nerves. The fancy word is a dermatome, but this is something that, again, clinicians are looking for. And if somebody comes in and says, I hit my funny bone and I have pain and tingling and numbness in these 2 fingers, I am thrilled, because that means it's very much predicting the path of the nerve. That informs what I'm going to do, and it makes it a little bit easier for us.
It's
All
more
right.
of a clear case.
What?
It's more of a clear case.
It's a little bit more clear because we have a better picture. Okay, so then to your question about the sciatic, we generally know there's a nerve issue. Does somebody have carpal tunnel? Did they have surgery on a nerve? Did they get a compression from something falling on them? So there usually is an injury to that part of the body that could be indicating that it's peripheral neuropathic. That is peripheral neuropathic pain. And then our last one, which is the most complicated and most devastating for people to experience, is nociplastic pain or central sensitivity. So there are different questionnaires that we can do to help us know if this is where someone is going. And it is so very important, because things that I will do with a sprained ankle from a week ago are very different from a sprained ankle from 5 years ago, where that person cannot function. I've had people who carry ice with them 24/7. I've had people who could no longer go to church because the vibration of the organ sent their leg into total chaos.
Wow. Okay.
So let's look at some of the key characteristics of the nociplastic pain. So we had a pattern with the nociceptive or the tissue issues. People that have nociplastic pain, there's no pattern. They hurt everywhere. They'll be fine. And then they have debilitating pain. It feels like it's spreading. And so there's no pattern. And unfortunately, many people don't understand this type of pain. So these are the people that don't get the support they need from their clinicians. So if your pain is wacky and it doesn't make sense, your pain is still real. I want to stress that again.
And just adding a little personal note for people listening, that this is where I fall into this category, and I call it pain whack-a-mole. It's like pain, its little head comes up out of one and you're trying to beat that head, and when it pops up over here and then it pops up over here. And then you start to think either your whole body is falling apart or you're going crazy. Those are the 2 things that you think, because you think, well, I can't have pain everywhere. Like, that doesn't make any sense. There's no diagnosis for that. Very frustrating.
There is central sensitivity.
Yes, yes, right.
All
Here
right.
we go.
So we could come back to whack-a-mole. We'll see how our time goes, or we can do this at the end because it's kind of fun. Okay, so then the other one is, we talked about how the pain and the injury match for the tissue issue pain.
Mhm.
When somebody has central sensitivity, their pain and their pattern, their injury doesn't match. So if they have carpal tunnel and they got it after being on a job for 1 week, that might be a little bit odd. If they have that carpal tunnel and then suddenly they are having carpal tunnel on the other side, even though they stopped working, or if they are now getting migraines, or they are now having GI problems or chronic fatigue, when we don't have a match, the symptoms aren't proportionate to what we would expect or what we've seen historically with other people, we have to get a little bit curious about the nociplastic pain. All right, we've got 2 more in our low game here. Okay, a huge one with the nociplastic pain is people have many different stress factors going on in their life. Stress is a driver of pain, period. But people who are dealing with significant family issues, work issues, financial issues, cultural issues, language issues, it can go on and on. This can definitely be a case for somebody being more likely to lead into that central sensitivity. And our last one. These are the people that hurt everywhere. There's actually a book, Where Do I Hurt? Why Do I Hurt? And people can feel like their pain is spreading. And that's a scary thing, to feel like your left leg was fine and now suddenly your left leg is killing you. It is less about the tissues in your leg and much more about the sensitivity of your brain and your entire nervous system. Okay, that was a long answer, so I hope that was helpful.
I love it. I love the props and the explanation, all very helpful, especially if this is a new topic for you. As Jen said, you can take notes, you can come back and look at some of this stuff later. In fairness, this is something that I've been on a quest to learn more about for over a decade at this point, and I'm still learning so much. And Jen's been so helpful. And she's, as she told you, still going to conferences. I mean, Jen, don't you feel like it's an ever, I don't want to say ever changing, but like there's just always, there's so much more to learn about it.
Yeah, the reason we know so much about pain is because of the introduction of CT scans and MRIs. Truly, before we had CT scans and PET scans, what's that, 30, 40 years ago? The pain model we were using goes back to Rene Descartes. And for those of you who don't know, he's a philosopher from 400 years ago. So in 1970, we're still doing pain as we did in the 17th century. So yes, it's constantly changing and we are always learning more, which is why I like to hear it over and over again. And yes, I still go to pain conferences and pain classes. I teach it. I'm always learning. Science is never done.
No, yeah, it's been fascinating for me, just, riding your coattails and learning as I go. I would think that a lot of people out there, and then this was me as well, I feel like when I first started delving into this, is you're trying to figure out, well, how do I know which one of those little jars I fall into? Like, how can I be sure? Like you gave us some indicators, but is that something someone might come to somebody like you to say, hey, can you help me figure out? Like, I think it might have started as a tissue issue, but I feel like I should have been healed by now. Have I moved into one of these other categories?
Yeah, so I like the way that you've described that because this is actually information that's used by clinicians. However, I think it's helpful to give just those couple of qualifiers so that you can start to wonder. Again, Kate, you said sometimes you feel crazy. You are not crazy. If you sprained your ankle 3 years ago and you still have pain, your pain is real. It just means that we need you to find the right clinician who can help you figure it out because the straight orthopedic doc or the straight orthopedic PT, they are doing the best they can with the information they have. And so, again, it's about finding the clinician that's going to help you really dive into your story and your history to know. And honestly, I don't tell people what bucket they're in. I do the evaluation, I get my information, and then together we decide a treatment plan. But I'm not going to introduce certain things if they're in one bucket versus another.
Right. So lastly, as it pertains to exercise and fitness, because I'm coming at it from the other side of it, which is that I want people to stay as active as they can. And you and I have known each other a long time, and I'm sure that over the years there have been times where you have been thinking like, okay, Kate, you could probably like maybe ease back a little bit or maybe shorten the duration a little bit, but you've never in all the years and all the tissue issues and all the central sensitivity, you've never once said to me, like, stop exercising. So is that, to me, that's a red flag when someone says to me, I mean, obviously there's obvious things. You broke your leg, whatever. But like, to me, I think what I'm always hoping people will do is they'll be a little more curious and they'll go out and find a clinician, like you said, who will help them work through this in a way that doesn't then take away some of the things that they love. Is that fair to say that like that's a direction you want to go where you would still have some activity in your life?
Yeah, I avoid the words always and never, just like in high school, multiple choice tests. It is so incredibly rare where I would tell somebody to not exercise. I might encourage them to do something different. Even when I was non-weight bearing for 6 weeks, when I had a stress fracture in my hip, I still did push-ups. I still did one-legged planks. So there's so much you can do to keep that movement. Why do we want you to keep moving? Because nerves require blood and movement to be happy. And happy nerves are not painful nerves. And so that's why the movement is so important. We actually know from the science that people who do nothing, they get more sensitive and have more pain. People that go too hard and they push through, we call that a boom and a bust. They also get more sensitive and have more pain. So it really is this Goldilocks place. And it's also like, I don't really like the phrase, but it makes sense. How do you eat an elephant? Do you know this phrase?
One bite at a time.
One bite at a time, right? So I'm not exaggerating when I had a client who she started out walking 2 minutes. That was it. And her goal was to go to Budapest. And you got to hike a lot of miles if you're in Budapest. And you know what? She did it. She sent me pictures 2 years in a row from Budapest because she was rocking it.
That's
So
great.
exercise
That,
is key.
That's honestly one of the things I love about teaching online, because we've talked about this a lot about how like no one's going to drive to the gym to work out for 5 minutes. Like that doesn't make any sense. But if you can just push a button on your laptop and join a class and do the 5 minute warm up and then be like, that's where I'm starting. That's where I am for today. And you can do that for a week or 10 days or 2 weeks, whatever you need to do. And then maybe you're like, I'm going to try 8 minutes. I'm going to try 9 minutes. So that's a beautiful thing, I think. And that's always what I'm trying to tell my people. Like, if there's a way you can move that that brings you some sort of joy, that's probably not going to be the same kind of way you move that brings you pain. That's not always the case, but if you can find that place where you're moving and you're enjoying it,
Mhm.
don't push it to the place where you feel the pain. Just do that little bit and be like, I felt that felt good and I'm done for today. So I think where I'd like to end this with is, because we started with May being Arthritis Awareness Month, and we've talked a little bit about arthritis. When we come back to that first example that we had, where someone has been told, they've been given a diagnosis of, you have mild arthritis, but they feel a little, a little tweak in their knee or their hip or their shoulder, whatever it is, when they exercise. Like, I want to get across to people is that it is safe for them to exercise with a mild diagnosis of arthritis. Now, that notwithstanding, neither of us are doctors. If your doctor tells you something specific, then you probably want to start with that and then maybe get a second opinion. But generally speaking, if someone has a diagnosis of a mild arthritis, would you say generally it is okay for them to still pursue some level of activity and obviously easing into that?
If I knew nothing about that person other than mild arthritis, my answer would be a wholehearted yes. However, each person is unique. So depending on what that person is bringing to the table might change that. If they're a person who doesn't have boundaries with themselves and we say, hey, go walk half a mile, and they're going to go run 5 miles, then we're going to have a different conversation. So what I will say globally, movement is key, because
Motion is
it creates
lotion.
safety in the knee. Motion is lotion. It creates safety in your nervous system. And when your nervous system feels safe, it calms down and you have less pain. Each individual person, I'd be very cautious to just say blanketly.
Of course.
So hopefully that gives you enough information.
Yeah. So if somebody wanted to get in touch with you, and ask you some more questions or do a consult, get some more information about the services that you offer, how would they go about doing that?
Yeah, so I have two websites. My physical therapy primarily is 180therapyandwellness.com spelled out. And then I also do pain and lifestyle coaching for people that aren't local or need something just a little bit different. And that's iriseforme.com. And can you put my email somewhere? Jen
Yes,
at
I will.
iriseforme. You'll just include that. Yeah,
Yeah,
cool.
I will put all of this in the notes when we post the video for sure, so that nobody has to memorize that. Although you're welcome to rewind and write
Uh,
it down, but
I'm
we'll
not
put
going
it
to
in
do
there.
it.
Jen, thank you so much. This has been super helpful for you guys who are out there. Just know that there are people like Jen out there who are going to help you navigate this path. I think for me, um, it's been a long journey, and just knowing that there was someone out there who understood what I was dealing with and how to start to navigate me through it. Jen is by far the first person who introduced me to the idea of learning more about pain science and the mind body connection and all of the pieces that go on. We literally could be here for 4 to 6 hours and I could pick Jen's brain and I would be all geeked out the whole time, and she probably would be too. But we figure that's too long of a video. But if you learned a lot from this and you are interested in learning more, please contact Jen or let us know in the comments and we will do more videos. I'm actually thinking I'm also going to offer an option where people can send us questions and we can get some questions answered. So hopefully this was helpful to you. Jen, thank you so much for your time. I really appreciate it. I know how busy you are with your businesses and your kids and your hobbies and all of that. So thank you for making the time, and we'll do it again soon.
Thanks, Kate. It was fun. It's always fun chatting with you.